Hello, good evening.
Hello, good evening.
Yeah, how are we doing?
We are fine by grace. How about you?
Great. I'm also doing well. Okay, so the last time we met, we were able to finish our discussion on BPH. I said the next time we meet, we'll start a new topic. So we'll be delving into the sexually transmitted diseases, so STIs. And the first one we'll be tackling, usually for the STIs, there are a lot of them, but we'll be tackling the STIs in terms of the ones that are similar. So we'll do gonorrhea and chlamydia. We'll do trichomoniasis, bacterial vaginosis. Then we also do syphilis with chancroid. Then herpes and what. So the ones that are similar, we treat them together. So for today, we'll be starting with syphilis and chancroid. So let's start. So basically, the first thing you should know is that syphilis is a sexually transmitted disease. So that's the first thing you should know. So syphilis is a sexually transmitted infection. And there are a lot of STIs. Some are caused by bacteria, some are caused by protozoa, some are caused by viruses. But syphilis is caused by a bacteria. Who can tell me the causative organism, the bacteria that causes syphilis? Any ideas?
Trichonoma pallidum.
Yeah, so Treponema pallidum. So Treponema pallidum is the causative organism for syphilis. All right. The nature of this bacteria. So you realize that for bacteria, classify them gram positive, gram negative, and all that. But the nature of this organism is that it's classified as a spirochete. So it's not classified as the usual gram positive, gram negative, those things. So this is referred to as a spirochete. I've typed this in the chat box, spirochete. So that's the nature of the Treponema pallidum. The Treponema species doesn't just cause syphilis, it causes a lot of conditions. It can cause other conditions like yaw. So we have this condition known as yaws or yaws. So it can cause yaws. It can also cause pinta. So I'm typing all of them in the chat box so that you see them. So aside syphilis, the Treponema species can cause yaws and also pinta. These are conditions usually present with dermatological manifestations. These are caused by the Treponema species. However, the species that causes syphilis is known as Treponema pallidum. All right. The next thing I want you to know about syphilis is that for the incubation period, the incubation period usually ranges from 10 to 90 days. So incubation period basically means the time of exposure to the time you start showing signs and symptoms. So when you're exposed, it may take 10 days for you to start showing signs and symptoms. Others, it may take 90 days. And it's usually co-infected. Syphilis is usually co-infected with other STIs. So it can be co-infected with other STIs like HIV, gonorrhea, chlamydia. All these can be co-infected with syphilis. As a matter of fact, when you have syphilis, you have 2 to 5 chances of getting HIV. So there's a 2 to 5 chance of getting HIV if you have syphilis. So you realize that once you have syphilis, your chances of getting HIV is high because it's a 2 to 5 fold. And some of the reasons that have been attributed to this is because when you have syphilis, usually presents with genital ulcer. And when there's an ulcer, it provides an easy passage for the HIV to enter the system, because HIV enters the system whenever there's a break in skin. Aside that, you could also have migration of, when you develop an ulcer, there's migration of white blood cells. And one of the major white blood cells that does migration to these genital ulcer are the lymphocytes. And the lymphocytes are basically the target for HIV. So HIV targets T lymphocytes. And the T lymphocyte HIV targets specifically is the CD4 cells. So the CD4 cells are T lymphocytes. So they tend to migrate to the area of the genital ulcer. So if you have syphilis, you develop a genital ulcer, you can have migration of these T lymphocytes. And that provides a target for the HIV to infect the patient. And during sexual intercourse, these ulcers are likely to bleed. When they bleed, blood is one of the mode of transmission for HIV. It gets into the system through body fluids like blood. So all these are some of the reasons why when you have syphilis, there's a 2 to 5 fold risk of getting HIV. So that's a brief introduction about syphilis. So we said it's an STI caused by a bacteria. We have a lot of STIs. We have that some are caused by viruses, some are caused by protozoa, some are caused by bacteria. But syphilis is caused by the bacteria Treponema pallidum. And we said this organism is a spirochete. Usually they have these spiral structures. So it's known as a spirochete. The incubation period is 10 to 90 days. And we are saying it's usually co-infected with other organisms. So other STIs that are co-infected with syphilis, HIV, gonorrhea, chlamydia. And we said that once you have syphilis, you have 2 to 5 fold risk of getting HIV. And we've given several reasons. That once there is a genital ulcer, provides easy entry for the HIV. The genital ulcer also can easily bleed, and blood provides a passage for the organism. And you could also have the migration of white blood cells like T lymphocytes, and these are targets for the HIV. So all these are some of the reasons why you have 2 to 5 fold risk of HIV when you have syphilis. On the other hand, for chancroid, so chancroid is also an STI just like syphilis. So we'll be doing compare and contrast. So we've just talked about a brief introduction about syphilis. So we are talking about chancroid now. So chancroid is also an STI, just like syphilis. Is also caused by a bacteria. However, the causative organism, who can tell me the causative organism for chancroid? Who can tell me the causative organism for chancroid? All right, so the causative organism for chancroid is Haemophilus ducreyi. Haemophilus ducreyi. I've typed it in the chat box. So that's the causative organism for chancroid. And this organism is a gram-negative organism. The other thing I want you to know about this organism is it's a fastidious organism. A fastidious organism. When you say an organism is fastidious, what it means is that this organism is difficult to culture in the lab. So it's difficult to take a swab and say you are going to culture Haemophilus ducreyi, because the requirements for you to culture, usually there are a lot of requirements. A lot of labs are not able to meet those requirements. In terms of the culture media, you may need serum for the culture of Haemophilus ducreyi. You may need a lot of carbon dioxide, high humidity. All these, a lot of them are not able to meet. So it's a fastidious organism. It's difficult to culture or isolate from the culture media. Chancroid can also be co-infected with other STIs. It can be co-infected with other STIs. So at times when you see a genital ulcer, you are torn between whether it's chancroid or syphilis, because genital ulcers can be caused by chancroid, they can be caused by syphilis. You can have genital herpes also presenting with genital ulcer. So it may present similarly as other STIs. The incubation period of the Haemophilus ducreyi is 4 to 7 days. So unlike syphilis, where it may take 10 to 90 days, it has a long incubation period. Chancroid has a short incubation period of 4 to 7 days. Other references talk about 4 to 10 days. Okay. And we said that they both present with genital ulcer. Both present with genital ulcer. Any questions so far? All right, so let's look at some of the clinical manifestations. So the clinical manifestation, no, let's look at the transmission route first. So the mode of transmission. So the mode of transmission, because it's an STI, the major transmission route is sexual transmission, right? So for sexual transmission, there are a lot of sexual transmissions. So it could be from the penile-vaginal intercourse. So penile-vaginal intercourse can lead to the spread of syphilis as well as chancroid. You could also have penile-oral intercourse or oral sex. So oral sex, it can be either way. It can either be the man at the receptive end. In that case, that's fellatio, or the lady at the receptive end. In that case, that's cunnilingus. So these are oral sex. Then you could also have anal sex. So anal sex is also one of the sexual transmission routes. The most common one is MSM. So MSM, men who have sex with men. So that's a very high transmission area. So we've talked about sexual transmission, penile-vaginal intercourse. So it could be the guy who giving it to the lady, or the lady giving it to the guy. Or oral sex, which we've talked about, could either be fellatio or cunnilingus. Then anal sex, with the predominant one being MSM, men having sex with men. So that's a high risk there. So these are sexual transmission routes. Aside the sexual transmission routes, we could also have vertical transmission. So when we talk about vertical transmission, basically with mother to child.
Dr. Chef, sorry for cutting. Please, can you spell the cunnilingus and the other one? Thank you.
Okay, so I'll type it in the chat box.
Thanks.
Okay. All right. So I was talking about vertical transmission. So vertical transmission is basically from mother to child. So an infected mother can transmit it to the child. So that's one of the established routes. Then aside that, we could also have blood transfusion. So blood transfusion. So that could also be one of the transmission routes. Just that nowadays it's rare because before there's any transfusion, they screen the blood for some of these organisms, whether they are Hep B, HIV, and all that. They screen. So blood transfusion as a route is now on the low. But aside that, you could also have other routes of transmission. Like for syphilis, you may have physical contact being one of the transmission routes. So you may not have any intercourse with the person, but because there was a break in your skin and you touched maybe the genital ulcer or any of the ulcers, you are likely to be infected. So we'll talk about that. So these are some of the mode of transmission. So sexual, vertical, blood transfusion, and physical contact. Any questions so far? All right, so let's look at the clinical presentations. So the clinical presentations, we start with chancroid. So for chancroid, you usually will get access to the body whenever there's a break in skin, usually a micro abrasion, you may not have seen it, or during the friction process, during intercourse, you can get cuts and the organism can easily enter the system. So basically, in terms of the clinical presentation, it presents with a genital ulcer. Unlike other STIs that are predominantly discharged, this one presents with a genital ulcer. However, the progression of the ulcer, we said once you're exposed, it may take 4 to 7 days for you to start showing signs and symptoms. Well, that's the incubation period. The first presentation will be the presence of a papule. So papule, I'll type that also in the chat box. So it starts as a papule, then it can progress to a pustule. Then the last is the genital ulcer. So the papule is basically an erythematous raised lesion that occurs at the site of infection. So if it's around the genital, it will appear as an erythematous raised lesion. And it's hard. So it's hard, erythematous, and raised. So usually around the genital. So it will appear as if you have a pimple or something, but it's hard. Then with time, it will progress to a pustule. A pustule is when you have pus. So now it's no more hard, but it's rather filled with fluid, and that fluid is pus. So that's what we call a pustule. And with time, the pustule ruptures to form the ulcer. So that's the progression. It doesn't just start as an ulcer, but it starts as a papule, which we have said is an erythematous raised lesion on the genital. With time, becomes filled with fluid. So in this fluid, in this case, is pus. So that's pustule. And with time, progresses to the ulcer, ruptures and forms the ulcer. So that's the progression of the genital ulcer. The other thing you should know about the genital ulcer in chancroid is it's painful. So it's painful. So you want to ask the patient whether there's pain or not. They usually will tell you it's painful. Then, in terms of the base, so the base of the ulcer is usually surrounded by exudates. So the ulcer base surrounded by exudates. So you have these exudates, these yellowish secretions just around the ulcer. So the base of the ulcer is usually surrounded by these exudates. And these exudates, once you try to scrap them off, the patient can easily bleed. So patients usually bleed from scraping of the exudates. These are typical manifestations of chancroid ulcer. And the base of the ulcer is also soft. So base of the ulcer is also soft. So when you check the base, it's also very soft. We are saying that the base is surrounded by exudates. And once you try scraping the exudates off, the patient can easily bleed. We are saying the progression is it starts as a papule, then progress to a pustule, and finally the ulcer. And we are also saying it's painful. All right. The other thing is, in terms of the ulcer produces fluid too as well. So it's a discharging ulcer. It's a discharging ulcer. So it produces its own fluid too as well. So you have fluid coming out from the ulcer. So this is a discharging ulcer. And this chancroid genital ulcer is also associated with lymphadenitis. It's associated with lymphadenitis or lymphadenopathy. So inflammation of the lymph nodes. Usually the lymph nodes affected are the ones around the genitals, so the inguinal lymph nodes. So usually affects the inguinal lymph nodes. So that's a typical presentation of the chancroid ulcer. So we said starts as a papule, then becomes fluid filled, which is a pustule, then the ulcer comes in later. Then we are saying the ulcer is painful. The ulcer base is surrounded by exudates and bleeds from scraping off the exudates. The base of the ulcer is also soft, and the ulcer we said is discharging and is associated with lymphadenitis or lymphadenopathy. Okay, let's talk about syphilis. So for syphilis, there are four main stages of syphilis, but let's just talk about the genital ulcer. So it also presents as a genital ulcer, just like chancroid. However, the ulcer is painless. Painless. So there's no pain associated with the ulcer. And this ulcer is usually referred to as a syphilitic chancre. So we usually refer to as a syphilitic chancre or chancre. So when you hear of chancre, usually we are referring to syphilis. All right. So they are saying the chancre or the syphilitic chancre is painless. And the ulcer base is not surrounded by exudates. The ulcer base is not surrounded by exudates, unlike chancroid, which is surrounded by exudates. And the ulcer is non-discharging. So it's a non-discharging ulcer. And the other thing is, the ulcer is usually a single lesion. usually a single lesion. For chancroid, it could be single or multiple. So for chancroid, the ulcer could be single or multiple. But with syphilitic chancre, it is usually just one ulcer, genital ulcer. And it's usually not associated with lymphadenitis. Usually not associated with lymphadenitis. And this chancre that we are talking about, whether you treat it or you do not treat it, it heals on its own. So the ulcer is self-limiting. Whether you give medications or you don't treat it, it's able to resolve on its own. So these are the difference in terms of the genital ulcer presentation. At times when they come in at a community level, you are unsure whether you are dealing with because they just tell you they have a genital ulcer, but you have to decipher whether you are dealing with syphilis or chancroid. So if a person is telling you that the genital ulcer is painful, then you think about chancroid, because syphilis is usually painless. Then if they tell you the ulcer is non-discharging, you think about syphilis. But if it's discharging, then you think about chancroid. Then you ask of the base of the ulcer. So the base of the ulcer, is it surrounded by exudates? If yes, then you are looking at chancroid. If there is no exudates, likely to be syphilis. Then you also want to find out the number of lesions. If it's one lesion, most likely it's syphilis. If it's single or multiple, then you can have that in chancroid. And you could also ask about any regional lymphadenitis. So if there's any regional lymphadenitis, like inguinal lymph node inflammation, then you think about chancroid. So these are the differences in terms of the genital ulcer. Any questions so far? All right. So let's look at the stages of syphilis. So the stages of syphilis. So there are 4 main stages of syphilis. So 4 main stages. The first one is the primary stage. Then we have the secondary stage. Then we also have the latent phase. So the latent phase. And the fourth one is the tertiary. The tertiary phase. So you have the primary stage, the secondary stage, the latent phase, and the tertiary phase. Basically, the primary stage, which is the first stage. The thing about syphilis is that syphilis can mimic a lot of conditions. So if you meet the case maybe around the secondary stage, you may be thinking it's a pure dermatological condition. Meanwhile, it's syphilis. If you meet the case in the tertiary stage, you may think maybe it's a neuro case or it may be a cardiovascular case. Meanwhile, syphilis. So it's very important to appreciate the various stages. So the first one, which is the primary stage, we said for syphilis, once you are exposed, it may take about 10 to 90 days for you to show the signs and symptoms. And usually, this primary stage is characterized by the presence of the syphilitic chancre. So it's characterized by the presence of the syphilitic chancre. So this syphilitic chancre, basically, we said that we've just described the syphilitic chancre as the painless. The ulcer base is not surrounded by exudates, non-discharging. It's a single lesion, not associated with lymphadenitis, and all that, and it's usually self-limiting. So for primary stage, the first thing that shows is the presence of this genital ulcer. And this genital ulcer, we said whether you treat it or you do not treat it, it resolves within some time. So it goes away with or without treatment. And this syphilitic chancre occurs at the point of entry of the organism. So depending on how the person got it, maybe we talked about the various sexual transmissions. So if it's penile-vaginal intercourse, we expect that the genital ulcer should be around the penis or the vagina. However, if it's a penile-oral intercourse, you realize that the presence of the syphilitic chancre may be around the mouth. So you may have the ulcer, the syphilitic chancre around the mouth. If it's anal sex, it will be around the anus. So that's how the patient will present. So depending on where the person got the infection, if there was a break in skin somewhere and the person got the infection, that syphilitic chancre would be present at the point of entry of the organism. So let's take note of that. Any questions? Okay. So from the primary stage, we'll go to the secondary stage. So for the secondary stage, this is characterized by the presence of maculopapular rashes. So you have these rashes on the body known as maculopapular rashes. So these rashes, some are appearing as macules. Macules are soft. These are lesions on the skin that are flat. So they are usually flat erythematous lesions. However, papules are raised erythematous lesions on the skin. And typically these are hard for papules. So you have a distribution of macules and papules. That's why we call it maculopapular. So maculopapular rashes. So we expect that to occur in secondary syphilis. The location of these generalized maculopapular rashes is typically around the trunk. So it's usually around the trunk where the chest, abdomen is. That is where you see majority of the syphilitic chancre of the secondary stages, the rashes. However, aside the usual places, the trunk, the legs, and all that, you may also have these rashes on the palms and below the feet. So palm and the base of the feet. So we usually use the term palmoplantar lesions. So palmoplantar. Palmo means palm. Plantar means leg. So lesions
Can you come again?
Lesions on the palm and lesions beneath the leg. So when you look at the sole of the feet, you can have some rashes at the sole of the feet.
Please, is that the latent fees? Sorry, please, I didn't hear you. So, please, where do the rashes come in? The one on the palms.
They are all secondary stage.
Okay, thank you.
So I'm saying for secondary stage, it's characterized by generalized maculopapular rashes. And this generalized maculopapular rashes, they are saying that the typical location for most rashes will be around the trunk. So you have majority of the trunk. So majority around the chest, the abdomen area. That's where you have majority. So around the trunk. You may also have it distributed on the limbs. So the legs, the hands, and all that. However, If someone is presenting with lesions on the palm and at the sole of the feet, you suspect syphilis first. Because if you have these occurring, these are not typical areas for dermatological conditions. So at the sole of the feet and in the palm, if you are having rashes there, suspect syphilis. And these rashes are usually non-itchy. So they are usually non-itchy. Unlike other dermatological conditions that may present with itching, for secondary stage syphilis, characterized by maculopapular rashes, you may also have some on the palm and also on the sole of the feet. And we are saying typically non-itchy. The infectious stages of syphilis are usually the primary and secondary. So if you see a genital ulcer, so if you have a genital ulcer, the genital ulcer usually contain some of the Treponema pallidum, so they can easily transmit to other people. The same way, when you have the generalized maculopapular rashes, some of these rashes may be harboring the Treponema pallidum, and that can spread it to other people. So that's why we were talking about physical contact. You may not necessarily have sex with the person, but if you have a cut and you touch the person who is in maybe secondary stage and has these rashes, you can also get it. Any question? All right. The other thing is that for secondary stage, it may also present with alopecia. Alopecia. So you realize that syphilis can mimic a lot of conditions. So if the person had maculopapular rashes, you'll be thinking about some dermatological condition, not syphilis. But if they present with you with alopecia, usually the nature of this alopecia is patchy alopecia. So patchy. What this means is that the hair distribution is not consistent. So you may have some hair there, then surrounding it, there may not be any hair. Then you find hair around another place. So it's sparsely distributed. So it's not a consistent pattern. So it's just scattered. So that's what we call the patchy alopecia. Then you could also have condylomata lata. So condylomata. I'll type it in the chat box. So we have condylomata lata. And condylomata lata is similar to condylomata acuminata, which is what? So condylomata acuminata is what? So it presents like what? So condylomata lata. However, you know what is flesh colored. So when you look at the color of your skin, that's how the color of a wat will appear. So it's flesh colored, and it usually looks like the cauliflower. So it's usually cauliflower-like. However, when you compare it to condylomata lata presents like a wat generally around the perianal region, the perineum, and all that. However, this condylomata lata is grayish. So it appears as grayish or whitish, unlike the condylomata acuminata, which is usually not grayish, it's usually flesh colored. So that's another thing to note about secondary syphilis. So aside the maculopapular rashes, you could also have alopecia, which is the patchy alopecia, or you could also have condylomata lata. Any questions? So if they present to you maybe at the secondary stage and the person has alopecia, you may not even think about syphilis. You may think about, let's get you some finasteride to help with hair growth, or we should get you some of these Kirkland products, minoxidil and all that. So you may not think about syphilis. All right. The next thing is the latent phase. The latent phase. The latent phase is subdivided into two. We have what we call the early latent phase, and we have what we call the late latent phase. So early latent phase and late latent phase. So what this latent phase means is, once you are around this stage, you are asymptomatic. So you do not show any signs and symptoms. You are asymptomatic. However, for latent phase, we said subdivided into early latent and late latent. So for early latent, basically refers to 1 year, if you are within 1 year of resolution of the secondary symptoms. So the secondary symptoms we talked about, the generalized maculopapular rashes and all that, they tend to disappear. So if they disappear and you are within 1 year of the disappearance of the secondary manifestation, then you are in the early latent phase. So the early latent, we are saying that is within 1 year of resolution of the secondary symptoms. So if the secondary symptoms resolve within 1 year, we've not shown any symptoms, then you are in the early latent phase. While the late latent phase is after 1 year. So after 1 year of resolution of the signs and symptoms in secondary syphilis, if you are asymptomatic for more than 1 year, then you are in the late latent phase. So take note of that. So early latent and late latent. Early latent within 1 year, then late latent after 1 year. The latent phase, because you are asymptomatic, you may not even realize it will just be with you. So there are certain stages where the latent phase has gone up to like 10 to 30 years. So it can even take very long. So you don't joke with it. The last stage is the tertiary phase. The tertiary phase is divided into three. So we have what we call neurosyphilis. Neurosyphilis. Then we could also have cardiovascular syphilis. So cardiovascular syphilis. Then the last one is what we term the gummatous. So gummatous syphilis. So these are the three main stages: neurosyphilis, cardiovascular syphilis, and gummatous syphilis. So let's take them one after the other. So basically, for neurosyphilis, realize that if you don't do anything about the syphilis, it can progress to the tertiary stage, and that tertiary stage is very is very advanced, because at that stage we may not do much about the treatment. You can't do much. The patient may lose their life. So that's why in the olden days, before the antibiotic came into being, there was a study that was conducted known as the Tuskegee study. And this Tuskegee study spanned from around 1932 to 1972. Basically, what they wanted to do is they wanted to study the natural history of syphilis. So they recruited about 431 Black people for this study without trying to get their informed consent. So they started them, they recruited these Black people for the study without any informed consent and explaining to them the details of the study and all that. So within 1943, where they discovered penicillins, and penicillins were shown to be active against syphilis, these people didn't give the treatment to those who were recruited. So even though a cure was seen around that time from the discovery of penicillin, but they never gave any drug to these 431 Black people. So a lot of people lost their life along the line, and that led to the major paradigm shift we have in clinical trials. That before you conduct any study, you have to get an informed consent. Then you also have to be sure that they understand the details of the study before recruiting them. And in the event that maybe something dangerous and possible drugs have been discovered, it's better they receive the drug rather than not giving them the needed treatment. All right, any questions? So I was talking about the tertiary syphilis as it can present as neurosyphilis, cardiovascular syphilis, and gumatosyphilis. So for neurosyphilis, from the name, you have the syphilis affecting the CNS, so usually the brain and the spinal cord. So these are the typical presentation. So it may appear as if the patient has meningoencephalitis, so inflammation of the meninges and also inflammation of the brain parenchyma itself. So that's meningoencephalitis. It could also present with issues with hearing, so otosyphilis. So the syphilis can affect your hearing, so it can cause otosyphilis. Then it could also affect the eye, causing ocular syphilis. So when it affects the eye, it causes ocular syphilis. So all these are part of the neurosyphilis manifestations. So meningoencephalitis, otosyphilis, and ocular syphilis. Then it could also present with cardiovascular issues. It can affect the heart or the vessels. So usually syphilis affects the vessels by causing inflammation to the aorta. So it can cause aortitis. So we have inflammation of the aorta, which is aortitis. So cardiovascular syphilis can cause that. It can also cause endocarditis, so inflammation of the endocardium, pericarditis, and all that. So all these are cardiovascular issues with syphilis. And the last one is gumatosyphilis. So gummes. So here there's formation of these granulomatous tissues known as gummes. So these granulomatous tissues known as gummes can form in certain areas, usually around the liver, in the brain, and also the bones too as well. So usually the liver, the bones, and the brain. That is where you typically have these gummatous lesions. So for tertiary syphilis, we talked about neurosyphilis, we talked about cardiovascular syphilis, and we just talked about gumatosyphilis. Any questions?
Can you repeat the areas that gumatosyphilis affects?
So I said it can affect the brain, the liver, and the bones. So liver, brain, bones. Okay. Any other questions? All right. So let's talk about diagnosis. So how do we diagnose syphilis with chancroid? So let's start with chancroid. So for the diagnosis, chancroid, we said the organism is a fastidious organism. So it's difficult to culture. But the first thing you want to take in every diagnosis is your history. You want to establish whether there is history of sexual intercourse. Then you look at other mode of what? Transmission. So you may not have had sexual intercourse, but you may have received blood which is infected, or you may have sustained a cut or something of which it wasn't a sexual transmission. So history is very important. You want to establish the root cause of the condition. Then you also want to do clinical examination. Clinical examination. At times you may be in the community pharmacy, someone has a genital ulcer and they want to show it to you because they feel like once you see it, you should be able to give them a better response. So clinical examination, you can examine the ulcer. And in examining the ulcer, if it's a chancroid, we've talked about the things you expect to see. For chancroid, we are saying that the ulcer base is usually surrounded by exudates and usually bleeds when you scrape them off. The other thing we said is that the genital ulcer is also painful. So it's painful in chancroid. Then there may be one or single lesion or multiple lesions. There can be a single lesion or multiple lesion. And we also mentioned the fact that for the chancroid ulcer, they usually have a soft base compared to the syphilis chancre, which has a hard base. And the chancroid base is not surrounded by exudates. Chancroid base is rather surrounded by exudates and it's easily bleeds when you scrape them off. So all these are the things that you want to find out in the history and also the clinical examination. The labs that can be used to diagnose chancroid, we said usually when you do a swab take to the lab, most of the labs are not able to culture because the organism is a fastidious organism. So most are not able to culture the organism. However, you can use this test known as nucleic acid amplification testing. Nucleic acid amplification testing. So that's what we call NAT. So NAT, which is nucleic acid amplification testing. So basically, this employs the use of PCR. You take a sample, then you try to check the genetic sequence for the Haemophilus ducreyi in the sample. So that's how you go about the diagnosis. You can also do microscopy, where you take a sample, then you view it under the microscope. And the last thing, which is culture, which is supposed to be the gold standard, because most patients are not able to, because most of the labs are not able to culture the Haemophilus ducreyi. We tend to rely on the history and clinical examination more often. Then we also do empirical treatments. All right, so for syphilis, the same thing. You start with the history, then you also do clinical examination. Clinical examination, you just want to find out whether the ulcer is painful or painless. So for syphilis, we are saying that the genital ulcer is painless. It's not surrounded by any exudates. Then, in terms of regional lymph nodes, there are no regional lymph nodes compared to the chancroid. And in terms of the ulcer base, there are no exudates. It doesn't bleed like chancroid. Then in terms of the genital ulcer, so it's non-discharging. So these are some of the things that you can find out. However, after the history and clinical examination, you still have to do some investigations to diagnose syphilis. So there are two main tests that you can do. And the two main tests are what we call non-treponemal test. So we have what we call non-treponemal test. Then we also have treponemal test. So non-treponemal test, then treponemal test. So for the non-treponemal test, these are usually semi-quantitative. These are semi-quantitative tests. And in terms of specificity, they are not specific. So they are not specific. They may be elevated or their levels may be high in other conditions. So we are saying it's semi-quantitative and not specific. Not specific. They can be elevated in other conditions. Examples of the non-treponemal test is what we call the VDRL. So VDRL stands for Venereal Disease Research Laboratory. So Venereal Disease Research Laboratory. So that's VDRL. Apart from the VDRL, we also have the Rapid Plasma Reagent Test. The Rapid Plasma Reagent Test. So all these are non-typical manifestations. Non-treponemal test, sorry. So non-treponemal test, we mentioned VDRL, Venereal Disease Research Laboratory, then the Rapid Plasma Reagent Test. These are semi-quantitative tests, and we said they are usually not specific. The next one is treponemal test. So treponemal test, basically, these are qualitative tests. Qualitative. So they'll tell you whether it's present or absent. So they are usually qualitative tests. And the treponemal example is fluorescent treponemal antibody absorption test. So we have a test known as fluorescent treponemal antibody absorption test. We also have, well, I'll type them in the chat box for you. So fluorescent treponemal antibody absorption test. Okay, so fluorescent treponemal antibody absorption test. We also have pallidum particle assay test. Treponemal pallidum particle assay test. All right, and the last one is microheme agglutination. So we have microheme agglutination treponemal test, treponemal pallidum test. Okay, so I've typed them in the chat box for you. So these are the treponemal tests. So the fluorescent treponemal antibody absorption test. Then we also have the treponemal pallidum particle assay test. Then we also have the microhemagglutination treponemal pallidum test. So these are treponemal tests. And we are saying that these tests are usually qualitative and they are more specific. These tests are usually qualitative and they are more specific. So the traditional method of confirming syphilis. So we have what we call the traditional method. That's what we know. You don't use one test to confirm syphilis. You always need two. So you do one non-treponemal, then you follow it up with a treponemal test. So that's the traditional method. You do one non-treponemal. So you can decide to do VDRL first to test the waters. Then you do the treponemal as a confirmatory test. So the treponemal test is the confirmatory. You do the non-treponemal to screen first. So that's what we do. So you can decide to do VDRL first. Then you follow it up with fluorescent treponemal antibody absorption test to confirm. However, there are some new regimen or new ways of testing. And this time around, they do it the opposite way. So they do the treponemal testing first. Then later, they do the non-treponemal. So instead of VDRL before fluorescent treponemal antibody absorption test, they rather do the VDRL first. They rather do the fluorescent treponemal antibody absorption test first. Then they follow it up with VDRL. Such instance is known as reverse treponemal test. So instead of doing the non-treponemal first and doing treponemal later, if you decide to do the treponemal first and follow it up with non-treponemal later, then that becomes a reverse treponemal test. Any questions? Okay, so that's that for the diagnosis. So that's how we diagnose syphilis. So use either treponemal or the treponemal first, then follow it up with non-treponemal or non-treponemal first, then later the treponemal. Okay, so let's talk about the management. So the management. So for the management, we start with chancroid. So for chancroid, we said the causative organism is Haemophilus ducreyi. So Haemophilus ducreyi is the gram-negative organism. So when you are looking for antibiotics, we look for usually ones with good gram-negative activity. So the preferred antibiotic we use is azithromycin. So we give azithromycin 1 gram start. That's the preferred method. So just a start dose is enough. Azithromycin 1 gram start. Or you can do ceftriaxone. You can do ceftriaxone, IM ceftriaxone. You can do IM ceftriaxone 250 milligram start. So IM ceftriaxone 250 milligram start, or azithromycin 1 gram start. The alternatives is the patient cannot take ceftriaxone or azithromycin. The alternatives, you can do doxycycline, or you can do erythromycin. So erythromycin or doxycycline can be used as alternative. All right. So that's how we treat chancre. It's very simple. Just a start dose of azithromycin, 1 gram start is enough, or 250 milligram start of the ceftriaxone. The alternatives, we said you can do doxycycline. You could also even do Cipro. So you can do ciprofloxacin. Once you manage the patient, you also want to give some medications to the partner to treat the partner as well. Because if they got it from their partner and you treat them, they'll go back to their partner. They are likely to get reinfected. We usually want to advise them if they have multiple sexual partners, they have to make sure they treat all of them. Just one person, they have to make sure they treat that person as well. And once you are on treatment, you don't have any sexual intercourse until you are completely healed or you are completely treated. So that's how we manage chancre. For syphilis, so the syphilis, the preferred agent is the benzathine. So we have benzathine penicillin. So benzathine penicillin. So that's the preferred agent to give. Usually you give 2.4 mega units start. So 2.4 mega units start. And the start dose, you usually divide it into 2. You give half, but then another 1.2 on the right butt. Or you can do around the shoulder, which is the deltoid. So you are just giving a start dose, and you should be giving IM. You shouldn't give benzathine IV. There's always that temptation because benzathine is painful. If you inject it, it's very, very painful. So because of that, even when you're injecting, you have to use lidocaine as the diluent for the dilution. So when you are giving, you should always go for IM. So that is that temptation to stop IM and do IV because the patient is complaining of severe pain. The risk of IV benzathine is when you give it IV, there's risk of cardiorespiratory arrest and also sudden death. So there has been instances of sudden cardiovascular conditions. So you can have cardiopulmonary arrest, and you could also have sudden death. So because of that, do not give benzathine IV. Always give it IM. So this will be done for someone with primary syphilis. So primary syphilis, you can give a start dose. Also for secondary syphilis, you give a start dose of benzathine. Then for early latent to a start dose of the benzathine. However, if the patient has a late latent or tertiary syphilis, then you have to do weekly for 3 weeks. So you have to do it weekly for 3 weeks. If the presentation the patient has is a late latent phase or the patient has a tertiary syphilis. So if they have a tertiary syphilis or late latent syphilis, then you do IM benzathine 2.4 mega units weekly for 3 weeks. Any questions? Okay, so If you are in the community setting, you can't give benzathine, right? So you may want to use an oral medication that is effective for syphilis in that instance. So you can use doxycycline. So alternative, you can use doxycycline. So for the doxy, usually 100 milligram BD for 2 weeks. So you do 100 milligram BD for 2 weeks. If you want to do azithromycin as an alternative oral, you can do azithromycin oral, but this time around 2 grams stat, not 1 gram stat. So azithromycin 2 grams stat.
Dr. Shak, please, the doxy and the azithromycin, please, is it for the primary to the early latent phase of the late phase of the syphilis, please?
Yeah, usually for that one is for the primary, secondary stages because these are not very advanced. So they are likely to come to the community pharmacy that they have an ulcer, they have these rashes and all that. So for primary, secondary, early latent, you do the orals as an alternative. However, if it's the tertiary where they are having neurosyphilis, they are having cardiovascular syphilis, it's better they come to the hospital to receive the benzathine weekly for the 3 weeks.
Yes, please. Thank you.
Okay. Any other questions? So the alternative, we've mentioned azithromycin, we've mentioned doxycycline. The other alternative you can do is procaine penicillin. So procaine penicillin, you can do 2.4 mega units of procaine penicillin IM once a day for 10 to 14 days. You do procaine penicillin 2.4 units IM for 10 to 14 days. So basically, they are all penicillin G. Penicillin G is the base compound. It's also known as crystalline penicillin. It's also known as benzapenicillin. They are the same. So if you hear of crystalline penicillin, benzapenicillin, or penicillin G, they are all the same. However, it's very short acting. So if you are giving that, you may need to give it every 4 hours. So we formulate it with either procaine, which is a local anesthetic, or you can formulate it with benzathine. So when you do it that way, it makes the penicillin G longer acting. It stays in the system for long. So you realize the benzathine is given once a week because it stays in the system for long. Okay. Any other questions?
Yes, Doc. Doc, please, how about the management of syphilis in pregnancy?
Okay. So for pregnant women, usually it's the same stage. If we come with primary, secondary, tertiary, we still manage you with the benzathine 2.4. However, if the patient is allergic to penicillin, you don't do doxy. Doxy should be avoided in pregnancy because of the risk of teeth discoloration and bone malformation in the child. However, you can do erythromycin. So erythromycin is safer in pregnancy. Then you could also do azithromycin. to an extent, but you avoid doxycycline. Hello.
Hello.
Hi.
Yeah. Sorry, I received a call. Do you have any questions? If you don't have any questions, I'll send you some questions right now so that you can quickly go through it.
Doc, please, I have a question. With respect to the use of benzathine penicillin in pregnancy, please, is there any gestational age limitation, or you can use it at any gestational age? And then with neonatal syphilis too, how is it managed?
All right, so I've sent you the questions. So you asked about pregnancy, whether we have to give it according to maybe first trimester, second trimester, third trimester. So usually for syphilis, we are looking at the risk to the child and the benefit of also treating the mom, because we said in terms of the mode of transmission, you can have vertical, mother to child. And syphilis can cause a lot of devastation to the child. So because of that, irrespective of the trimester, whether it's first trimester, whether it's second trimester or third trimester, so far as the patient has syphilis, you would have to treat. And you treat with benzathine, whether it's first trimester, second or third. So irrespective of the trimester, you can treat. Then for children, the preferred one is to do the benzapenicillin or procaine penicillin instead of the benzathine. You know, the benzathine is very painful and it stays in the system too for long. Because of that, we prefer to do the penicillin G, which is the benzapenicillin, and the procaine, which is it's less painful because of the local anesthetic. The procaine, which is a local anesthetic, it reduces the pain. So you can do that for children. So that one you would have to calculate based on the body weight. So if you are doing procaine penicillin, it's usually 50,000 units per kilogram per day for 10 to 14 days. Then if you are doing penicillin G, which is benzapenicillin, that one is 100,000 to 150,000 units per kilogram per day. That one is given IV for 10 to 15 days. So these are some of the recommendations you can do for children.
Okay, thank
Hello, Doc. Please come again with the doses.
So I said procaine penicillin, 50,000 units per kilogram per day. So 50,000 units per kilogram per day for 10 to 15 days. Then the benzapenicillin is 100,000 to 150,000 units per kilogram per day, also for 10 to 15 days or 10 to 14 days.
Thank you.
Do you all have the questions? So one of you can share your screen so that we go to the questions. Is someone sharing their screen?
Yes, please. Please, I'm about to project. Hello. Please, can we all see the
Yeah.
screen? Okay. So Kweku Frimpong, a 28-year-old long-distance driver who normally plies the Accra-Kumasi road, presented to your facility with complaints of appearance of a sore on his penis. He stated the lesion had no associated pain. On direct questioning, he explained he has multiple sexual partners and his last intercourse was a month away. On examination, presence of single lesion at the gland penis, non-discharging with rolled out edges. The attending physician prescribed the following: IV benzathine penicillin 2.5 mega units weekly for 3 weeks, and then azithromycin 1 gram stat. Cap azithromycin 1 gram stat. Question 1. What is the most likely diagnosis of Kweku Frimpong?
All right. So, what's the most likely diagnosis?
Syphilis.
Yeah, syphilis. Can you justify why syphilis?
No associated pain.
Yeah, so no
Non-discharging,
associated pain.
rolled out edges.
Yeah.
Single lesion.
Exactly. So it's a single lesion at the glans penis, non-discharging with rolled out edges. Usually the edges for the syphilis are usually round. However, chancroid, you have irregular edges. So that's also another difference. Then
No associated pain. So 2. Based on your answer in 1, which stage of the disease is Kweku Frimpong in?
so which stage? Which stage is the patient?
The primary stage.
Yeah, so the primary stage, because of the genital ulcer, the chancre, it only occurs in the primary stage. We said after primary stage, whether you treat it or you do not treat it, it resolves on its own. Then you progress to the secondary where you see the rashes. Okay.
Okay, 3. What are the risk factors that predisposed him to getting this condition? Multiple sexual partners.
Okay, multiple sexual partners.
Recent
Long
intercourse.
distance driving. Any other risk factor?
The age.
Yeah, so the age is within the sexually active ages. What again?
Please, what about the fact that he's a long distance driver?
Okay. Why long distance driver being a risk factor here?
And please, what we've been hearing is that because they are long distance drivers, they are not usually at home. So like on the way, they have plenty girls on the way. So for every stop, they have somewhere they will go and
Okay, all right. So there has been that assertion that long distance drivers may have multiple sexual partners on their journey. So it's likely that they may pick some of these infections. Okay. Any other? Any other? Okay. Some may argue that because the sex is male, the males are usually predisposed to getting more STIs. So, in terms of prevalence, you may see more STIs in males. So, there may be some assertion that the male sex predisposed you. But now, in the female sex, a lot of people also have these STIs. So, these are some of the risk factors identified in the case. Let's move on.
4. Comment on the appropriateness of the prescription.
All right. So, any comment on the prescription?
Okay, so since it's a primary, according to what we just heard, for primary syphilis, we do the benzathine penicillin 2.4 units stats. But here he's being given 0.4 units weekly for 3 weeks, so it's inappropriate.
Okay, so that's true. It's a primary syphilis. So the weekly for 3 weeks is not appropriate. Just a start dose is enough. What again?
And the route of administration
They
of the
give it to
benzathine
him as IM.
Come again. Come again with your answer.
Sir, please, it was given IV instead of IM.
Yeah, so the route of administration, instead of IM, they did it IV. All right, what again? Any other?
And then
Erythromycin should be 2 grams stat instead of the 1 gram stat.
Yeah, so the erythromycin should be 2 grams stat instead of 1 gram stat. Any other? Any other thing?
So you either do the benzathine penicillin or azithromycin. It's not together.
Exactly. So when you get a question like that, comment on the appropriateness. You say everything about the appropriateness. So don't just say some and leave some. So you talk about the IV route of benzathine. It's supposed to be IM. Then you talk about the fact that primary syphilis, so it's supposed to be a start dose instead of weekly for 3 weeks. Then the fact that they are combined benzathine with azithromycin. The treatment is a monotherapy. It's either you are doing benzathine or you are doing azithromycin. And the dose of the azithromycin, instead of 1 gram stat, 2 gram stat. So you comment about everything concerning the appropriateness. Let's move on.
5. What alternatives would you recommend if Kweku Frimpong is allergic to penicillins?
So which alternatives?
You can do erythromycin.
Okay. Erythromycin, what again?
Doxycycline.
Doxycycline. Okay. What again?
Azithromycin.
Okay. All right. So all these are alternatives. If you get a question like that and they ask you the drug, so you give the alternative and you also give the dose that you want us to give. Else, if the mass is supposed to be 2, they may give you 1. It's always best to state the drug and the dose. All right, let's move forward.
6. Which tests can be recommended to confirm your diagnosis?
Okay, so risk test. Any ideas?
We can do the venereal disease and research lab test. We can do the other qualitative tests also.
Okay, that's all. Okay,
You can do
so the test we are
Treponema
doing.
pallidum particle assay test.
Okay, go ahead. Okay, all right. So when you're recommending the test for the diagnosis, we don't just do one test. We do 2 tests to confirm. So you do the non-treponema tests like VDRL, then you confirm with a treponema test like the fluorescent treponema antibody absorption treponema. So that's the followed with the preferred way of doing the diagnosis.
Seven. Name
Let's
two
move on.
differential diagnoses that could present with genital ulcers.
So 2 differential diagnoses.
Chancroid and herpes.
Yeah, so chancroid, herpes, both present with genital ulcers. So in this case, if you go and write gonorrhea, chlamydia, you'll be wrong, even though they are differential diagnoses, but they do not present with genital ulcer. So the ones that present with genital ulcer, they can have aside syphilis, chancroid, herpes, and other ones.
8. Should Kweku Frimpong's multiple partners be treated as well?
So should they be treated?
Yes, please.
Okay. So they should be treated. So once you are treating the patient in front of you, you also give them some medications to be given to the partner. Because if you don't treat the partner and the person goes back to the partner, they are likely to be reinfected. So you always want to treat the partner. What's the name given to that practice where you give medications to be used by the partner? What name do you use? And practice where you give medications to be taken by the partner.
Expedited partner therapy.
Yeah. So the expedited partner therapy. So the expedited partner therapy. At times it's very difficult. If maybe the man has gone to contract an STI from the side chick and they are supposed to take medication to their wife. It's would be like they don't have any symptoms. They've not had sexual intercourse with someone else. So why are you bringing them medications to take? Sometimes it can lead to marital issues. It's very dicey. But that's the way to go. You treat them and you give medications to be used by the partner. Okay.
9. Is Kweku Frimpong at risk of contracting HIV/AIDS? Explain.
So is he at risk?
Yes.
Yeah, he's at risk. So what are some of the reasons why he's at risk?
Due to the presence of the open source, if he has sexual contact with an infected person, he could easily contract the virus.
Okay. So you mentioned several points that once there's a break in skin, there's an ulcer. It allows for easy passage of the HIV. Then the ulcer could also bleed in blood. The mode of transmission for the organism HIV. And we also said once there's a genital ulcer, you have migration of white blood cells like lymphocytes. And these are targets for HIV. So once you have syphilis, you have a 2 to 5-fold risk of developing HIV. Okay, let's move on.
10. Kweku Frimpong started having fever, headaches, joint pains, and rapid heart rate after receiving benzathine penicillin. What is the most likely cause of this?
Okay, so what do you think is happening? Any ideas?
Please, I'm trying to. Okay, so I think this is what we call a JH reaction. So it happens when those with spirochete infections, such as this syphilis, are treated with antibiotics. They usually present with the symptoms is presenting about, such as the headache, the fever, and the joint pains.
So call it the Jarisch-Herxheimer reaction. So the Jarisch-Herxheimer reaction. So I've typed it in the chat box. The Jarisch-Herxheimer reaction. So this is a response that occurs when you give the antibiotic So when you give the antibiotic, it tries to eradicate the organism Treponema pallidum. As they are dying out, these dying treponemes are able to elicit an inflammatory response. So they induce an inflammatory response, which is characterized by a lot of cytokine release. And because of the cytokine release, it causes these constitutional symptoms like fever. You may have myalgia, you may have chills, you may have joint pains and all that. Typically, these occur within the first 24 hours, and they tend to resolve with supportive therapy. So if you give, because if they're having headaches, joint pains, you can give analgesics like PMO. If they're having fever, you can give antipyretics. So that's what we do for them. So it's because of the dying treponemes, the Treponema pallidum, they are able to induce that inflammatory response. Term for that is the Jarisch-Herxheimer reaction. Okay, I think that was the last question, right? Do you have any more questions?
Yes, please.
Okay. So if you don't have any more questions, we'll end here. Hopefully the next time we meet, we'll start with trichomoniasis and bacterial vaginosis.
I have a question.
Okay.
My question is in relation to the question 8, if the partner should be treated. So in this case, will it depend on the severity of the case? Would they have to present to the pharmacy or something? Because what if it's not early stage? What if it has progressed then or something? And if it hasn't, will you then do the start dose of benzathine, penicillin, or azithromycin or Doxy?
Yeah, so it will also depend on, so maybe the person who is in front of you is already in maybe primary, secondary, or tertiary. So it will depend. If the person is already in the tertiary and you are doing the three doses weekly for 3 days, weekly for 3 weeks, and the partner maybe is maybe having a chanker, so it's in the primary stage, that partner will just take a start dose. So the principle is that they should be treated as well, but the treatment is dependent on the stage. Any other questions? All right, so we end here. Hopefully another time. Have a good evening.